Hi, good evening, everybody, and welcome back to Fertility Care from Everywhere, which is our Monday night show where we come to you live from the CNY Fertility Global Travel Team and just kind of talk about all the things that are unique to you as travel clients. So for those of you who are watching, maybe this is your first introduction to CNY Fertility, but we do a really good deal of our client base comes from a distance away from one of our local offices. And the way we're able to do that is because we have you do all of your monitoring, your testing. We do that remotely in your local area so that you can stay home for the duration of your treatment cycle. And then when it's time for your egg retrieval, your IUI, your transfer, you're able to actually then come to the office, have that procedure, head back home, and then continue on with your monitoring, once you get home. So tonight, our talks are just, our Monday night talks are primarily just to answer your questions. Sometimes I come with a topic. Tonight I did not. We're just gonna start answering your questions. So drop them in the comments. We'll give a few minutes for people to join with us, but it looks like Cindy from Texas has joined us. Hi, Cindy. And Medina. Hi, Medina. Talk about nonstop fluid in the uterus and cervix. Well, we will talk about that for a moment here. Hello, Miranda. Cindy, that's phenomenal. First beta 209 and second 582. Girl, that is a strong little one you got going in there. Congratulations. That's amazing. Amazing. Okay, so while people are joining us, again, Elizabeth from CNY Fertility's Global Travel Team. We're the friendly nurses that you speak to as we manage your cycles from afar. And so it looks like we've got people from North Dakota, from California. It's so fun to see all of the places that we're able to kind of to touch. And that's kind of why we started calling this show Fertility Care from Everywhere, because no matter where you are, we can help you. So let's jump right into questions. I'll just kind of start at the top. Medina, your nonstop fluid in the uterus and the cervix. So fluid buildup in the uterine lining is it's not highly uncommon, but it can present issues where if there's fluid buildup in the uterus, the embryo is sort of, not able to properly adhere to the wall of the uterus and begin that process of implanting, burrowing into the lining, and then sort of developing from there. And so, Medina, in your specific case, I know, you've tried a lot of different things, but the primary thing that we use to tackle fluid in the uterus is our antihistamine protocol, often with the addition of Mucinex. However, if that's not kind of drying things up, then we may need to look at some other options. And so that's about the extent of my knowledge with fluid in the uterus. Like I said, typically it responds to the antihistamines, but this could be a response to the level of estrogen that's in the body. And so if that's the case, I can't recall if you've tried a natural cycle where we stimulate the body to grow a follicle, grow an egg, and then ovulate that and use that as our method of thickening the lining. So I'm not sure if you've tried that, but that could be a potential option. But it's definitely throws a monkey wrench in plans in terms of moving forward. And I'm so sorry for that, because, I think I must say this every time I come live to you, but none of us imagined this process as a part of our journey to motherhood. And so it's hard enough to have to endure the injections and the ultrasounds and the travel and all of that. But on top of it, to run into unforeseen things like having, fluid in the uterus that we can't seem to get rid of is really hard, because that presents even another challenge that the whole thing is hard enough as it is. And so my prayers and positivity are with you, Medina, that we can figure out a way to get this taken care of so that we can, help you get to that big positive pregnancy test and ongoing, so you can bring a baby home. Let's go with another question. Sarah, this is an awesome question. So Sarah is asking, what day of the cycle should preconception blood work be done on? So preconception blood work is a panel of labs that are highly, highly recommended, not required, We feel very strongly here at CNY Fertility that it's our job to give you recommendations in terms of your best chances, but it's your body, it's your money, and it's your time. And so you have the right to decline any testing that you do not wish to pursue. However, with that said, preconception testing, the majority of it really can be completed on any cycle day you like, because things like infectious diseases, complete blood count, complete metabolic panel, comprehensive metabolic panel, CBC, CMP, those things are not going to change. The values are not going to change relative to your cycle day. There's a couple of labs that we do like to see on a specific cycle day, primarily estrogen, progesterone, and FSH. FSH is probably the most important one. So FSH is a hormone that's naturally secreted in your body from your brain, from your pituitary gland, as a sort of internal stim, if you will. So we talk about stims and stimulation cycle. That's your body's own natural stimulation. And so we know that that number is going to be at its peak around cycle days 2 to 4. And so ideally, if you want a really accurate FSH level, you're going to want to try to get that to fall between days 2 and 4. But all the other preconception blood work, for the most part, can really be done any day of the cycle. In fact, if you go on cycle day, 15 for your lab, your preconception labs, we will be able to tell, because we'll be able to see some fluctuations in different areas. But the most important one in terms of the preconception blood work to do on a specific day is going to be that FSH. But we will actually test that FSH at each baseline, because that data means something over the long term. If we're able to see that your FSH primarily hangs out in a certain area, but then you go for baseline and you see that your FSH has doubled for some reason, that might be a good indication that this is not the cycle to stim on. Let's prime your body, bring the FSH down a little bit, so that we know we're working with something a little bit more ideal. So that's kind of the answer on cycle day for preconceptions. Hello from North Dakota. Let's see here. Jessica is asking, husband had a PESA less than a week ago. We've reached out via phone and portal to review his report. What can we do? I'm assuming that you're having trouble getting his report. Do me a favor, Jessica, if you're a travel client, send a message to the Global Travel Questions inbox, and we will look into that tomorrow for you to see how we can get that. I don't know where his PESA was, if it was in Syracuse or if it was outside, but we definitely would. I'm sure you were very interested in knowing what those results are. So definitely send a message to the patient portal. If you send it to Embryology, like I said, maybe send it over to Global Travel Questions, and hopefully we can get that answered for you, so that you know what you're dealing with. Miranda from Texas. All right, cool. So Sarah, next question is, what day of the cycle should the saline sonogram be done? So unlike the preconception blood work, which has, it's pretty open in terms of when you can do it, a saline sonogram is really important to be done early in the cycle. So we don't want you to do it so early in the cycle that you've still got shedding endometrial lining from your menstrual cycle. But we don't want to do it so late into the cycle where your lining has thickened up to the point where we won't be able to get an accurate picture of what is in the uterus. So a saline sonogram is just that. It's an infusion of saline through a very small catheter that's sort of abutted against the cervix, and saline is infused into the uterus. So the uterus normally sits kind of in a closed position like this, and that saline sort of blows the uterus up like a balloon, so that we can see what the internal contour of the uterus is. And this is the gold standard. Well, hysteroscopy would probably be more the gold standard, but sonohistogram is a great diagnostic tool to look for any type of what we call intrauterine filling defects. So something that would be considered an intrauterine filling defect would be a polyp. So if we see a small polyp in the uterus, which you can sort of liken that to if you've ever had a skin tag, a polyp is kind of like a little skin tag inside the uterus. And normally we wouldn't really be concerned about that, except for that little polyp doesn't really have its own network of blood supply to adequately support a pregnancy. Your embryo cannot burrow into that polyp and begin implantation. And so if the embryo attempts to attach to that polyp, we're going to end up with a failed cycle. And so uterine polyps should always be evaluated to see if they are in a place where we know they're going to impact the successfulness of the transfer. What we also see is we can see fibroids on the saline sonogram. So again, we're blowing up the uterus and we're looking, is there a nice smooth contour, or are there lumps and bumps in there? Because again, a fibroid, especially depending on the position of the fibroid, so not all fibroids need to be removed or addressed, but some fibroids that are impeding the endometrial contour, those fibroids can actually inhibit implantation, because once again, your embryo cannot burrow in and start the implantation process into a fibroid. And so fibroids, especially those that are listed as submucosal fibroids, those are fibroids that we want to have evaluated to make sure that those are not going to be impacting your transfer. And so, the way I like to think of it is, if we know that fibroids can impact pregnancy, especially the submucosal fibroids. But if you don't do a saline sonogram as a part of your preconception testing, sometimes we find these things on your ultrasound at your lining check. So in the instance of a frozen transfer, you're going to go for a baseline. You're going to have an ultrasound and labs. Ultrasound, the standard transvaginal ultrasound, is not really a good diagnostic tool for the location of fibroids and the involvement in the muscle or in the endometrial tissue. So if you've decided to skip that test, then what do we do when you go for baseline? Things look good. Remember, ultrasound, standard transvaginal ultrasound, is not the gold standard for diagnosing polyps and fibroids. So they're easily missed. But then what happens if you go for your lining check a week later, and now we see something that we say, oh, this might really negatively impact the transfer? Now what do we do? Because a lot of clients feel kind of forced into, well, I've spent all this money on monitoring, and so I guess I'm just going to go for it, which I can certainly respect that. But, once you do this type of work for enough time, you really do realize what an absolute miracle it is. And I think all of you here, if you've had, any extensive time trying to conceive, you understand that it is a miracle when we're able to successfully make this happen. And so why would we leave anything to chance? Why would we leave something we know can negatively impact a transfer? Why would we leave that? And so sometimes the way that I like to look at this is, while of course any type of delay is devastating, it really is. However, is that delay going to be devastating when you end up with your positive pregnancy test, your ongoing pregnancy, and your delivery? You'll think very little about that delay. And I always tell this story. So if any of you have ever spoken to me on the phone before, and I've had to maybe deliver some bad news that we had to, postpone or something like that, I always give the story about how there was about a 6-month set of circumstances between my own retrieval and my eventual transfer, just due to different factors. So it's 6 months. I mean, that's a long time. But ultimately, I wanted to put my body in the best possible position to get the outcome that I was hoping for. And so while the delays feel really big now, when you're holding your baby, you won't be thinking about those delays. You'll be thinking about the joy of finally getting to where your goal was. And so all of that to say, your original question was, which cycle day should that saline sonogram be done on? And ideal is between days 5 to 10, 5 to 12. Because again, we don't want your lining to be so thick that we mistake thick endometrial tissue for something like a polyp. But we also don't want you to still be bleeding, because little blood clots and things like that can sort of give us the impression that maybe there's a polyp that's not really a polyp. So the answer is days 5 to 12 is ideal for a saline sonogram. And that also goes for a hysterosalpingogram, the HSG. And while we're on the topic of the saline sonogram and the hysterosalpingogram, so SHG and HSG, I know we couldn't have thought of anything that was more similar. I get a lot of questions about, why on earth do you want me to get a tubal test, an HSG, if I don't need to use my tubes for the process? So for IVF, we don't need your tubes. We're going to go directly into the ovaries, extract the eggs, inseminate them in the lab, and put them back in the uterus. No tubes required. So why do you care what my tubes look like? And the answer to that question is because if you've got unhealthy tubes that are secreting inflammation into the pelvis, that inflammation can be toxic to the resulting pregnancy. And so we want to make sure your tubes are nice and healthy, your uterus, the inside of the uterus, is nice and clean and ready. So these are why we ask you to do these preconception testings. And I really can't overstate that, again, not required, but we recommend them for a reason, because they are really helpful in hopefully identifying things that we could fix so that you do get that outcome that we're looking for. So, all right, next question. Please talk about beta and when we get to do ultrasounds. Okay, I will try. I think I know what you're asking, but if I mess it up, just comment again. Your first beta, your first blood pregnancy test, which we call beta HCG, is going to be done usually about 10 days after the transfer. When that is positive, then you're going to go back 48 hours later. So 2 days later, you'll go back for a repeat to make sure that that level has gone up at least 66%. So I hear a lot of discussion, about doubling, and the HCG should double every 48 hours. Technically appropriate, all of a sudden I have the hiccups. Appropriate rise in HCG is at least 66% every 48 hours. So if you go for your first beta and it's 50, you go for your second beta and it's 85, 90, that's great. You're going to go for your first OB ultrasound 1 week from your second beta, as long as it rose appropriately. So that's kind of what you can plan on is transfer day, 10 days later, I do a blood pregnancy test. 12 days or 2 days after that, I do the ultrasound, or the second beta. And then a week after that second beta is when you would go for your ultrasound. And typically, as long as if you go for your first ultrasound and we see a nice, healthy gestational sac with a yolk sac, a fetal pole, and a heartbeat, we're very likely going to discharge you to your OB. If there's anything we have any questions about, we'll hold on to you another week or two just to make sure that things are going the way they should. Not everybody sees a fetal heart rate at your first OB ultrasound, which can be really disheartening if you don't know that that's possible. But yet it's very common. If you go, in that middle to the end of the 5th week of pregnancy, it's 50-50 whether that heartbeat is going to be there. And so if we send you, we see a nice gestational sac with a yolk sac, we don't yet see a heart rate, we're going to send you back in a week. We're going to make sure that heart rate has started and is appropriate. But once everything is appropriate, baby is growing, heartbeat looks good, levels look good, off you go. So if you're watching this and you do not have an OBGYN, you need to get one ASAP. So it's really hard for us to have you have access to local resources once you are pregnant if you don't have an OB. And a lot of OBs, are booked out a bit. And so it's really important now, sooner rather than later, to get get established with an OB. That way, when the time comes, you've got you've got resources and you've got someone locally who can care for you. Sometimes we'll see bleeding in early pregnancy, and that can be really, really terrifying. And if you don't have an OB, your only other option is going to be able to go to an ER. And unfortunately, ERs are just not good places for early obstetrical issues. For whatever reason, anything related to OB in the ER is kind of like a hands-off type of thing. And so, you don't want to be stuck having to go to the ER when you could just establish an OB now. That way, if there's any concerns, you can address those. Next question from Kristen. Just got my cryo report today. 338 frozens. That's great. That's awesome. How many days approximately will it be before we transfer? Well, that's a good question. Oh, you froze them. Okay. So since it'll be a frozen transfer, you can expect your next menstrual period to come on. It's usually between 10 and 14 days from the retrieval. And then from cycle day 1 to transfer is usually 14 to 18 days later. So it ends up being about a month from the retrieval that you'll have your embryo transfer. Awesome. Oh, hello from Mississippi. Somebody else I think is from Mississippi. That's awesome. Let's see here. Shaquana, patient of Albany office and have some issues, concerns. I'm so sorry. You can actually message through the patient portal to Global Travel Questions, and I myself will keep an eye out for your message and we'll get you taken care of. All right, next question. Ashley, I'm going to put this on the screen, but it might block my face out. Yep, that's what I thought. I'm going to take it off the screen. Okay. So Ashley's question is, can levothyroxine affect a cycle? I started it last Saturday. I was supposed to start my period Thursday, but only had some red. Ended up starting a few days later. Just curious of what cycle day 1 would be considered for next month. It's full flow. That's right. So full flow red bleeding, that's what we call day 1. So if you spot for 4 or 5 days before your actual full flow comes, that doesn't count. That first full flow, like, oh, yep, it's here. That's day 1. Levothyroxine, I mean, I can't really see a good reason that it would affect your menstrual cycle coming. It depends on, I suppose it could depend on what your levels were before you started it. But that's not one that I've heard too many people complain of it kind of messing up or making your cycle wonky. This might have just been an off month. Sometimes our bodies do that. Okay, let's see here. Emily, Dr. K just called me today and he added Omnitrope for my transfer. I used it for my retrieval, but not for transfer. Anyone else used it for transfer? This will be my 4th with 3 failed. Oh goodness, Emily. Well, here's hoping that 4th one is a charm. Omnitrope can help with development of the uterine lining. And so we do often use Omnitrope for the transfer portion. It's started typically at your baseline for FET. So when you call cycle day 1 and you get your call from the nurse once we've received all of your results, the Omnitrope would be started then. And then we would continue that Omnitrope until the day before you start your progesterone. So it's usually 10 to 12 days maybe on the Omnitrope. There would be no harm in starting it now if you wanted, if you had plenty of it, but primarily that is introduced at the baseline to the FET. All right, let's see here. As Stephanie is saying, I'm planning to start everything at the beginning of September. Do I need all of the medications prescribed? Not entirely sure when your consultation was, if you've been spoken to since you had your consultation. This kind of leads into the next question from Sarah, which is how long after the consultation do you start? So as Stephanie, if you've already had your consultation and you're well established with us, you should be getting your medications probably middle of August. So if you haven't had your medications prescribed and sent out to one of the fertility pharmacies, send a message through the patient portal if you're a travel client to our travel inbox. Or if you're a local client, you can send to any of the nursing teams in your local area. And we'll make sure that we get those medications sent in for you, because you do want to have those in hand before your period starts, whenever you're ready. So, and then Sarah was asking, how long after a consultation do you start? So usually after consultation, you will get a phone call from the nursing team. Usually somewhere between 1 and 3 weeks. It just depends on our volume. We truly do get to these new patient consultations as quickly as we possibly can. But what we try to do is after your consultation, within a day or two, we try to give you some tools to kind of help in the meantime. And those tools are in the form of 3 packets that we upload to your patient portal. So within, like I said, usually 24 to 48 hours, if your consult's like on a Friday afternoon, you might not get them till Monday. But what we do is we go in and we upload a packet of information. And it's just called the Global Travel Packet. That one of the best things that you can do for yourself is read that from cover to cover. I cannot tell you how many questions that you have that will be answered by that Global Travel Packet. So I've said this before, but a lot of the nurses here, we all knocked our heads together and really tried to make that packet not a bunch of fluff, but information that you actually really truly need. So that's the first thing. The second thing that typically gets uploaded is a packet of lab orders that includes all of that pre-testing. So you don't have to wait for one of our nurses to reach back out to you in that 1 to 3 weeks after your consultation. You don't necessarily have to wait for us to give you a call to just go get those labs drawn. So the lab packet will have orders for the preconception blood. It will have orders for the SHG and the HSG. And then usually your partner in his portal, if applicable, will have an order for a semen analysis. And so what you can do, if you've done prior fertility workup, you can kind of look through all of your records and see, have I had any of these tests done in the last 6 months? Yeah, great. No need to repeat them. If the tests have been outside 6 months, probably worth repeating, because once again, we don't want to rush only to find out that there were things that were preventable that caused the failed transfer, things like polyps, fibroids, those types of issues. So it is just so important to have those tests done, so that we can make sure everything is as good as it can be. But with that said, Sarah, as soon as you'll have your new patient consultation, you'll get a call from the nursing team, the travel nursing team, like I said, 1 to 3 weeks later. And then as soon as you get your medications in hand, you call us cycle day 1 and you can get started. So let's say you're due, your consult was 2 weeks ago and you get a phone call tomorrow and we order your meds and they can be delivered Friday. You can call with your next period and get going. Or alternatively, you can start anytime you want after that. That's the soonest you can start. But is typically, once you have had your follow-up with the nurses from the global travel team, and then you've got your pre-testing done and your meds in hand, we can get you started. So, all right, let's see here. What else do we have? Question-wise. All right. So Bree says, I had a successful transfer back in early 2019. Congratulations. Now we are on number 4 of FET and no luck. Should I look into ERA? Even though the first successful transfer I did the standard amount of progesterone, can it change? Yes, it can. So I will tell you the story of one of my dearest friends who had a successful transfer on her first attempt. And then a couple of years later came back, did a transfer. Unfortunately, it failed. So then she did the ERA and her receptivity was off. So any type of major changes in medical history, any type of uterine surgery, so C-section, there's a lot of different things that can change that sort of window of receptivity, that window of implantation. And so it definitely could be conceivable that perhaps your progesterone window has changed and it might be worth doing an ERA. So I would definitely consider looking more into that because that certainly could be a possibility. Let's see here. So Zaida, I'm so sorry if I said that wrong. Question about male factor. Is 0% normal morphology with low counts in all other areas a serious cause of concern? I mean, it certainly can be. The good news is that because we perform the sperm injection or ICSI on all of the oocytes that are retrieved, that is that overcomes a lot of male factor infertility problems. However, low count, not that big of a deal. We need as many we need as many sperm as you have eggs. So that part we can usually easily overcome. Depending on what morphology concerns there are, that certainly could play into poor fertilization. But that's something I would really encourage you to discuss with a provider a little bit further to see what could we implement to improve your husband or your partner's overall parameters. And so what lifestyle changes, what medications, what things could he do to improve those numbers? That's something we should definitely look at. Okay, so let's get rid of that question. Taneha, how long should you take mechanics? I'm thinking you mean medications. I'm not sure there. Ask that question again, and so I can clarify. I don't want to answer it wrong. Sylvia, when will I know it's time for a retrieval? Do they tell me one day and next day I will have to fly over? Or will I know a couple days in advance? This is a great question, Sylvia, one we get all the time. So from the trigger shot itself to the egg retrieval itself is 35 hours, so about a day and a half. You're most likely going to get your trigger phone call by 5 p.m. the day of trigger. So that adds an additional 6 hours or something like that. So it's about 42 hours notice at the shortest. But sometimes if, let's say you went for monitoring today and we said, you know what, Sylvia, you need one more day of medication. So let's trigger you tomorrow for retrieval on Thursday. So then today's Monday, you would know today that your retrieval was Thursday. So somewhere between 40 hours and maybe 2.5 days is the kind of, is the kind of window that you're looking at. But it is a much shorter kind of heads up in terms of time than further transfer. Usually we have more time because you need a certain amount of progesterone in your system prior to transfer. So that's usually something like a 5 to 8 day notice, whereas the retrieval is something more like 2.5 to 3 day notice. So, but it does come up rather quickly. All right, Medina, yes, we will. We will get this done one way or another. We certainly will. And I'm sorry I missed you last week. I was out of the office, but I am back. Okay, let's see here. Sarah, this is an excellent question that I am going to, well, I lost it. Hold on. Sorry, this thing is sometimes a little tricky in terms of where the questions go. Well, I missed that. I missed that question. Sorry. Yeah, I can't find it. I was going to answer your question, Sarah, but it kind of disappeared on me. All right. So next one. Oh, wait, here it is. It was about a donor. There we go. There we go, Sarah. Okay. If you have your own egg donor, are there a lot of extra hoops to jump through? I am not a member of the donor team, so I don't want to misspeak, but I do know that if you have your own egg donor, that's certainly going to probably help speed the process along because you're not going to need to get on a waiting list and things like that. But there is a workup that is required to be done on all donors that does add a little bit of time, to the process. But I would say send a message through the patient portal to the donor team and just let them know that you're planning or hoping to use your own egg donor and just get an idea of what that time frame is, because there certainly are hoops, so to speak, to jump through. I just don't know how many there might be. So, Shantae, I had a consultation June 4th. When do I get the ball rolling? Shantae, if you had your consultation June 4th and we have not called you yet, please do me a favor, send a message through the patient portal. What happens is after the consultation with the provider, that provider sends a note over to the travel team to indicate that you're ready kind of to move on to the next step. Every now and then, that task or that note will inadvertently get closed. So let's say our financial team sees that first and they reach out to you. Sometimes that will inadvertently get closed or vice versa. We'll see it first, we'll close it out, but then the financial team did not get a chance to reach out. So if you've not heard from us since June 4th, I apologize. deeply apologize. And I would just ask if you could please send a message through the patient portal to the global travel team, and we'll get that taken care of for sure. Okay, I'm so sorry about that. Okay. Can you guide me about beta numbers? Transferred 2. When do I expect to do an ultrasound? I'm about to be 5 weeks. Current beta is 582. You know, usually you do see some higher numbers when we transfer 2 if they've both stuck. So not always though. I think 582 was your second beta, so that's pretty good, but not crazy high. But you'll do your ultrasound in probably about a week from your second beta. So I think you said 582 was your second beta. So you can expect to do a retrieval, or sorry, you can expect to do an ultrasound in about a week. So hopefully that helps. All right, next question. How long should you take Mucinex for fluid in the uterus? That's typically taken until you start progesterone. Mucinex is something that we don't typically recommend in early pregnancy, whereas the other antihistamines in our antihistamine protocol, Benadryl, Pepcid, Claritin, those are all continued through, I believe, 10 to 12 weeks. But Mucinex is typically stopped once we start your progesterone. All right, next question. Shanador. What a great name. I probably said it wrong, but it's beautiful. During stims, should our follicles produce a specific amount of estrogen? Yes, they absolutely should. That is where the estrogen is coming from. It's coming from the developing follicles. So the rule of thumb is that each mature follicle secretes around 200 units of estrogen per follicle. And so in the absence of using letrozole in your stimulation, so if you use letrozole, that little calculation doesn't pan out because letrozole blocks the estrogen in the blood. So the follicles are still growing and developing, but you just can't get a read on how many there are based on the estrogen, since the letrozole is sort of inhibiting that. But usually we see, like I said, it's somewhere between 100 and 300. So take the middle, 200 units per mature follicle. And so that can be a good indication that things are going well. Now, if we see, let's say you're not taking letrozole and we see the ultrasound is saying that there's 10 follicles that are all 12 millimeters, but your estrogen is really low, that would cause us some concern because we expect as those follicles grow and develop, they are secreting that estrogen. That's where the estrogen is coming from. So, all right. Nanu, hi, what level the FSH is supposed to be at baselines? There's no magic number. We do know that stimulation is probably going to be a little bit harder once you get above FSH is above probably 12, 13, somewhere in that neighborhood. But ultimately, that FSH is just an indication of how hard your brain is working at baseline to develop one follicle. So if that number is really high, that says, wow, my brain is having to work really, really hard just to build one follicle. So we're never going to tell you no, you can't start. What we'll let you know is, all right, FSH is a little high. It might take us a little bit longer, or we may have to increase your medication doses a little bit to get the desired response. Next question from Heather. If using donor eggs, how many is recommended to transfer? Almost across the board the answer is 1. If for some reason you are using a known egg donor who was older, the guidelines on number of embryos to transfer is based on 2 things: the age of the egg in the donor, however old the donor was, or however old you were at the retrieval, combined with the age of the embryo. Is it a day 3 embryo or is it a day 5 embryo? So we know day 5 embryos are much more likely to go on in ongoing pregnancies than day 3s. And so for that reason, the ASRM guidelines, the American Society for Reproductive Medicine, they say that that transferring 2 day 3s is going to be more acceptable than transferring 2 day 5s, because we know day 5s have a much higher chance of implantation and ongoing pregnancy. With a donor, especially if that egg donor is young, it's almost always going to be to transfer 1 at a time. And that's just a matter of keeping you safe. I say all the time, everyone, not everyone, but plenty of people say, oh, I'm okay with twins. And that's great. twins are wonderful, but they are high risk, and they do put you at high risk, and it puts the babies at high risk. And unfortunately, twins isn't the only thing that can happen. Unfortunately, you can put in two, and those both embryos can split, and you can end up with 4 babies. And so when we counsel you on the number of embryos to transfer, it's always with your safety in mind. So I hope that helps. Maria, and looking at your FSH and LH seem high. Unfortunately, not knowing what exactly those values are, it would be hard to say. So send a message through the patient portal and just ask if somebody can review that, so we can see if we do think that that's something that's going to be kind of negatively impacting. And there are things you can do in some instances to lower your FSH, but that FSH is just like I said, it's an indication of kind of what to expect in this cycle. So, all right. Amber is asking, I've been taking the recommended supplements for 3 to 4 weeks now to prepare for retrieval in September. I'm so sorry, I have the hiccups. My cycle is always 26 days. Today is day 19, and I have been cramping and started bleeding pretty heavily. Can the supplements cause an irregular cycle? Certainly they could. I don't know which supplements that you're on, but absolutely. A lot of these supplements are intended to regulate your hormones so that your ovaries are functioning at a healthier level. And so when you start making changes, you're going to see changes in your ovary, or in your ovaries, and in your cycles. So it's not uncommon to see fluctuations in the amount of cycles. Now, for it to be only 19 days, that's pretty short, but it could be your body sort of acclimating to these supplements. And I would also throw in there, if you've embarked on Dr. Kiltz's keto, that can also cause a change in cycles. And that's a wonderful indication that we are lowering insulin resistance and improving your ovarian function when cycles start to become a little bit more regular, that type of thing. So that certainly could be the reason why your cycle has changed a little bit. Let's see here. When does embryology follow up after retrieval? So my understanding, Marcy, and I could be misspeaking here, but I do believe that embryology only reaches out once the cycle is completed. So from my understanding, you don't get a day 3 sort of report unless all of your embryos are frozen on day 3. So you'll get your fertilization report the day after the retrieval, and then you'll get an end of cycle update once your embryos were frozen. And hopefully I'm not misspeaking there. I'm not an embryologist, so but that's my understanding, that you'll get that cycle update once the cycle is complete. Okay, this is a wonderful question from Rivera. How long will I need to continue taking the transfer meds? So they all are sort of titrated at a different time in the pregnancy. And so if you've watched me before, I talk a lot about trying to understand the why. Why do we take these medications? Because if you don't understand why, then you can make decisions about your medications that can negatively affect your cycle. So for example, in a frozen embryo transfer that's done medicated, where you take estrogen, you grow your lining. Once it's thick enough, we time out the progesterone to match the age of your embryo, and then you transfer. That has all sort of been artificially done with hormones from the outside. And so once you become pregnant, those hormones from the outside are all that is supporting the pregnancy. And so for that reason, since the placenta does not take over production of those vital hormones until at least 8 weeks of pregnancy, that's when medications will start to be weaned off. So we typically start weaning your prednisone at 8 weeks so that you're off of it by 10 weeks. We typically have you take your estrogen through 10 to 12 weeks, and both of the progesterones about the same. 10 to 12 weeks is the stop date, because we want to, if we know your placenta is going to take over production of the hormones around the 8th, 9th week, we want to be extra careful and make sure that that is full on before we withdraw those external forms of progesterone and estrogen. And then some of the other immune medications are withdrawn at different points, just depending on what they are. So that's a really good question. But once you start those the estrogen and the progesterone, those are so key to making sure that you are going to support that pregnancy the best that you can. All right. Rakia, again, I'm not great at pronouncing names, so forgive me. Do you guys have an office in Florida? As a matter of fact, we do. It is not open just yet. My understanding is that in the next couple of weeks, it will be a monitoring center similar to our Atlanta office, our Rochester office, but it will not be full service IVF for some time. But it is located in Sarasota, Florida, and we are really excited to be able to offer those monitoring services, like I said, to get started, and then eventually full service lab is really, really exciting. Next question from Miss Ashley. Can you explain how birth control works for timing of cycles? I sure can. So what we do with birth control pills, it's used for a couple of reasons. One is to time out a cycle. So we know that you all have lives. Your jobs don't stop. Your other responsibilities don't stop when you embark upon fertility treatment. And so some people choose, especially, depending on what your job is, a lot of teachers will choose to use birth control to time when their period is going to start. And so what we can do is, if you take birth control pills consistently, usually for at least about 10 to 12 days, once you stop them, your body will start from there. So you'll have a period, that's cycle day 1, and now we're in control. So let's say, Ashley, let's say you're hoping to do a retrieval September 15th, okay? And we know most people stim for 10 days, trigger on the 10th day, retrieve on the 12th days, and you want it on the 15th. So count back 15 days, count back that 12 days from the 15th. And then we know that's around when we want you to start your period. So if you stop your birth control pills 4 days before that day you want you to start your period, you're going to start your period and off you go. And so one of the other benefits of birth control pills for some people is if you have what we call desynchronous follicular development, meaning there's a group of eggs growing that are down here that are all kind of one size, and then you've got another group of eggs that are developing that are a different size, and we're not going to be able to get the group of them in that mature window at the same time. What you can do is use birth control to down regulate the ovaries. Essentially, you tell all the follicles to shrink down to one size such that when you begin the stimulation, they all grow as a group. Not everybody responds well to birth control. Many people do well with it. But absolutely, if you're trying to time a cycle out, we can absolutely use birth control pills, knowing that we'll start your stimulation 4 days after your last pill. And that can really help time things out. Now, it's not a perfect science. So let's say we do that and you wanted your retrieval on the 15th, but you only ended up needing to stimulate for 7 or 8 days. Obviously, that's going to change things. So we can control a lot, but we can't control everything. And so, we try, but that's kind of what we use birth control pills for in terms of timing a cycle. Savannah, question, is brown spotting at 5 weeks, 3 days okay? It is absolutely okay. Terrifying? Yes. Any tinge of blood, of brown, of anything when you're pregnant feels like a huge deal. But spotting, brown, especially brown spotting, is usually tied to a little bit of cervical irritation, either from an ultrasound probe, intercourse, even coughing or sneezing can sometimes cause a little bit of bleeding from the cervix that then, makes its way out as brown spotting. Totally normal. What we want you to watch out for is any bright red bleeding that is copious, that is like a period. That would not be considered normal. It very well might still be okay, but it's not something that we would consider normal. We would definitely want you to let us know. But brown spotting, 100% normal. Okay. And then you also asked, Savannah, can low HCG levels turn out to be a healthy pregnancy? I've seen it. I've seen some pretty amazing things happen. And so, yes, it depends on how low. But yes, I have seen what I would have thought when I first glanced at it. Oh, this doesn't look so great. Turn out to be just fine. And so, yeah, absolutely. All right. Caitlin, what is the timeline like for frozen mini IVF, assuming everything goes well? And can it happen in one cycle? Okay. Yes. So mini IVF is like a low dose stimulation intended to get a decent number of eggs without you breaking the bank on a huge medication bill. The good news about the mini IVF is usually your estrogen levels are a little bit better controlled. So it's estrogen levels at the trigger and the retrieval that kind of determine whether or not you can do a fresh transfer. Well, but you said frozen mini IVF. So I'm not sure if you were talking about doing a frozen transfer. So mini IVF, again, smaller doses of meds. You go through the stimulation and the retrieval just like any other protocol. And then you can freeze everything and come back when you're with your next period to transfer. Or if everything looks good, your lining is nice and thick and trilaminar, your labs look good and safe, we could do that. Could all happen in one cycle. It would not necessarily have to be a frozen cycle. If everything looked good, you could do it in one cycle. Maria, oh, you looked up your levels. Yeah, an FSH of 43 with a LH of 32. I mean, that's pretty high. It definitely could be worth discussing ways to potentially bring that FSH down prior to stimulation. This might be something where you want to do a follow-up talk with one of the providers to sort of look at the big picture and determine what is our best way forward. So thanks for looking those up, though. That was really helpful. Okay. All right. So I had 14 follicles last month. I started the birth control for 2 weeks, and now I only have 5 follicles. Is birth control the reason for this? I think is what you mean. Possibly. So again, the birth control is a sort of down regulator of the ovaries, meaning it quiets them way, way down. And when it does that, sometimes your ultrasonographer isn't going to see every tiny little antral follicle. So I would be surprised if you went from 14 to 5. I'm wondering if it's more not a case of they're all now nice and small, and she's just seeing 5, because birth control. And now again, not everybody does great with birth control. So it could be the case, but for the most part, it seems that, as you start to stimulate, now all of a sudden we see all those 14 follicles kind of come back around. All right, Becca, this is a wonderful question we get a lot. I don't get cycles on my own. Is it necessary to take a medication to start the cycle, or do I just send a message when I'm ready for my baselines? So it is not necessary to induce a period if, when you're ready to get started, you call us, we send you in, and everything is looking low, meaning lining is thin and hormones are low. So if you go in and we see that, oh, your estrogen's 300 and your progesterone's 6, that tells us you're actually probably going to get a period sometime soon. But if you never get cycles on your own and you're ready to get started, let us know. We'll send you in. As long as everything is nice and low, we can absolutely get started. You do not have to have a period to start a cycle. It's all about, what is your body telling us? Is it at baseline or is it mid-cycle? That's the most important thing, but you do not have to have a period to start a cycle, to start a treatment cycle. Okay. This is a good question. Jana, my cycle should start around August 14th. When should I start ordering my medications? I would try to have your medications in hand the week before. Because if your cycle starts a few days early and you're not expecting it, I would try to have the medications in hand about a week before. That would be great. Okay, let's see here. Cindy is saying progesterone level is low at 12.2 and that it should be 20 plus. My OB says it's in range. Should I be worried? So I say this kindly, but most OBs are not used to managing fertility cycles. And so, 12 isn't a bad number, but we know that in a medicated transfer cycle, so if you did not trigger for this transfer, we really want that level to be above 20. So I would send a message through the patient portal. I know I say that a lot, but I can't really individually, kind of handle each of you here, but send a message because you're taking the pills, you can't handle the shots. Well, let's see what else we can do. Maybe we can increase your oral intake or your vaginal intake or something. But we really do like that level to be above 20. We know that's most supportive for a healthy pregnancy. Jana is hoping to have a retrieval in August. That's exciting. So you'll want to get your meds. You just want to get your meds at least a week before that expected period. All right, fresh eggs versus frozen eggs. Is there really a difference? Is one better than the other? That is a very good question for the donor team. I want to say that fresh eggs are probably better, only in the sense that you're inseminating them fresh. You're not freezing, thawing, inseminating, refreezing. But please direct that to the donor team. They're really the experts in that area, and I would hate to overstep. Okay. Sarah, I lost both my tubes during 2 separate ectopic pregnancies. I'm so sorry. Do I still need to do the HSG or just the saline sonogram? Yeah, so the HSG, if you don't have tubes, is irrelevant. So you can just do the saline sonogram. Josie, this is a really, really good question. And we are running out of time already. When is the best time to get the COVID vaccine after a fresh transfer? Being forced to do it and retrieval transfer is next week. Well, I would say if there's any possible way you could wait till you get to like the 6-8 week mark of pregnancy, that would probably be ideal, only because you don't want your body. We know overactive immunity is a very common reason for miscarriage. And so we don't want your body to go into a huge immune flare, which we know it's going to do, right? That's what the vaccine is intended to do. Perhaps, what you might want to think about doing is get the vaccine now and do a frozen transfer. Get yourself fully protected and then come back for a frozen transfer, so you're not trying to get it all in at the same time. But if you really, really, really want to do a fresh transfer, I think I would say probably maybe wait till you see a nice strong heartbeat and everything's going well, and then you can kind of discuss with your OB. But without a shadow of a doubt, CNY Fertility, the American College of Obstetrics and Gynecologists, and the American Society for Reproductive Medicine all unequivocally, as well as the CDC, recommend the COVID vaccine. Pregnant, trying to become pregnant, any of the above, the complications of COVID are far, in the eyes of ACOG and ASRM and the different governing bodies, are far worse than the vaccine side effects. Allison is asking, what's the difference between a 3-day and a 5-day transfer? It's just simply that when the embryo is being put back. So if it's being put back day 3, it's considered I believe it's a morula. I might be saying that wrong. Versus a blastocyst is the day 5. We do know that blastocyst embryos have a higher implantation rate and a higher ongoing pregnancy rate. But with that said, the body really is the best incubator. And so if you have 4 or more good quality embryos on day 3, we're going to grow those out to day 5. Again, we know day 5s have a better chance of implantation. However, if you have 3 or 4 okay looking day 3s, we want to freeze those on day 3 because your body is truly the best incubator. And so we want to give those the best chance we can in your body. So day 5 is statistically has better chances of implantation and ongoing pregnancy, but day 3s do really well also. So it really just kind of matters, how many do you have on day 3, and do we need to freeze them then, or do we need to grow them out? Okay, let's answer. My goodness, let's try to pick 2 more questions. Let's see here. What is the idealistic level for estrogen for retrieval? Thank you for your time and your help. Well, you're welcome. My pleasure. So we say there's no real ideal level. There's a too high So, when you start getting levels above 3,000, we start really worrying about ovarian hyperstimulation syndrome. But as long as you have between 100 and 300 units of estrogen per each follicle we're seeing nearing maturity, that's really what we look for. That's kind of the ideal level. So for me, if I only have 4 eggs and my estrogen's 800, that would make sense. If you have 20 eggs, your estrogen is going to be a lot higher. And so it's more a matter of, does it match up? Does the picture match up? And like I mentioned a little bit earlier, if we see you've got 10, 12 millimeter follicles, but your estrogen's 100 and you're not taking letrozole, something's going to perk up, like what's going on here. So there is really there is no ideal level. It's more, is that appropriate for the overall picture that we're seeing? Sarah answered this a little bit earlier, but Florida, Sarasota should be open in the next few weeks, I believe, for monitoring. And then we'll be looking at a full IVF lab, at some point in the future. And I don't have an exact date for that. Alethea is asking, is Tylenol the only thing you can take for headaches while on stim? Yeah. We don't like you to take ibuprofen if you can help it. We always say, obviously you have to function. So you have to kind of do what you have to do, but Tylenol really is the safest thing that you can take in stimulation. Just did my 3-day fresh transfer on 7/23. That's awesome. Is mild cramping and bloating common? It sure is. That's awesome. Yeah, mild cramping is just a sign that the uterus is at work. And bloating is a pretty common side effect from the estrogen. So I would say so far so good. All right, let's pick one last question. This is a good one. Thank you for asking it. So Zan, maybe. I'm planning to do egg freezing the end of August, 1st of September, depending on my cycle. The last medication list I received was for IVF. Will the same prescription be used if I'm only doing egg freezing? Not quite. So there's a handful of medications that are used for, if you're not doing egg freezing, you're doing full IVF. There's a handful of medications that are not used for egg freezing. And those medications are typically the endometrium or prometrium, the progesterone in oil, the estrace, and if it was prescribed, Prograf. But if you have any questions, just send a message through the portal to the travel team if you're a travel client, or the local office, and just have somebody double check. Hey, looks like now I'm only doing egg freezing. Can we just double check so I don't get meds that I don't need? Because that does happen, and we don't want you to end up getting meds that you don't need. So, all right. Well, that is it for tonight. I chatted away here, and now we're past time. It was really nice to have a chance to engage with you guys. I really want to impress upon you to be gentle and kind to yourself as you go through this process. It's something, like I always say, none of us ever expected ourselves to be in this situation. And so be kind to yourself. Positivity and persistence really do go a long way. And never hesitate to ask, when and if you have questions. And as I say every week, if you guys have specific topics you want me to discuss, I know if I'm lost for a topic, I know I'll have plenty of questions to answer. But if there's things that you guys really would like to learn more about, please let me know. I usually try to look back through the comments and see if there's any topics. But I'll be back next Monday, which is going to be August 2nd. And then I will actually be taking a little bit of a break. So I won't see you guys for the next few weeks after that. But I will be back next week. We'll talk over DOR patients at Shenandoah. That might be a good topic for future discussion. So, but without further ado, I will leave it at that. I wish you all a wonderful, wonderful week and lots of success. We'll see you soon.